Thank you for joining us for Conversation in Hematology Oncology. During this segment, we'll be discussing the efficacy of bispecific antibodies in large B-cell lymphoma and indolent B-cell lymphoma. I'm Dr. Gilles Salles. I'm the Chief of the Lymphoma Service at Memorial Sloan Kettering in New York. And I am joined by my preferred colleagues, Dr. Matthew Lunning from Omaha, Nebraska, and Dr. Sweta Kambhampati from City of Hope in California. So we will discuss during this session the recent results that were achieved with this new family of drugs, these bispecific antibodies binding on one side to the tumor side, on the other one to T cell, and bringing T cell to kill these tumor cells. So they were initially developed in patients with advanced disease who had failed 2-3 lines of therapy. So Dr. Kambhampati, can you go back and tell us a little bit what were the results of these drugs as single agent in patients that had failed prior therapies, and maybe starting with a patient with diffuse large B-cell lymphoma?
Sure. Thank you so much, Dr. Salles, for that question. As you said, these bispecifics have really shown promising response rates, including in heavily pretreated patients. And we have 2 now that are FDA approved for relapsed refractory diffuse large B-cell lymphoma. One is epcoritamab, and the other is glofitamab. In the pivotal studies, looking at their single agent activity, the response rates in both of them overall are about 52%, 63%, and the CR rates are very comparable, about 39%. And the response rates in the cohort of patients who received prior CAR T and did not seem to be comparable.
Dr. Lunning, I think there have been attempts to combine these bispecific antibodies with chemotherapy, something that may be not straightforward given the fact that chemotherapy may have an effect on T cells. Can you comment on the combination of these drugs, and do you think it really adds to chemotherapy in the salvage setting?
Yeah, we're just starting to see some initial results of some of the prospective trials that are bringing these bispecific antibodies with chemotherapy. There's also, bispecific antibodies that have been tried with agents like lenalidomide and indolent lymphomas, and then throwing them together with our more intensive salvage regimens in diffuse large B-cell lymphoma, trying to increase the CR rate and taking more patients likely to an autologous transplant. I think the one thing that caught my eye specifically was starting to look at these high-risk populations, these are double hits or triple hit patients, where I've classically went to dose-adjusted EPOCH-R. I think there was a presentation at this ICML by Dr. Felci, which broke out a subpopulation of that double hit, triple hit patient population. And really, I think it's too early to tell, but I was very encouraged by the complete response rate in that subset of high-risk patients, not only by their genomics, but I think also, which is hard to get is those high IPI patients. And those are really where I think the primary refractory disease patients live. And so if I can continue to see high response rates with durability in that population, I can become a believer, that I was asking the same question about what was bispecifics going to bring in a chemotherapy setting. I bet you we were asking the same questions when we were adding rituximab to CHOP back in the day too, and only with time, was the story further written. But it's an exciting time to be doing research in non-Hodgkin's lymphoma.
So thank you for that. Dr. Kambhampati, can I come back a little bit with these 2 agents that we have, glofitamab, epcoritamab? What are the differences? What are the similarities? Do you see one can be preferable to the others? Are they equal? Right now, they are both approved for patients who have failed at least 2 lines of therapy. Where do you use them in your patients today?
Yeah, thank you for that question, Dr. Salles. So I think both epcoritamab and glofitamab are a great option for patients who have relapsed refractory disease, even in the post-CAR T setting, which is a high unmet need. I think it's hard to compare between studies, but the response rates appear to be comparable between the pivotal trials leading to each of their approval. Some differences to consider are epcoritamab is subcutaneously administered versus glofitamab is intravenous. Glofitamab is a fixed duration, whereas epcoritamab is indefinite in the approval. And both have step-up dosing to mitigate some of the toxicities. Glofitamab has the addition of a pre-treatment obinutuzumab dose, which helps with potentially dampening the T cell activation by depleting some of the B cells. But I think both are very effective, and it becomes a discussion with the patient preference in terms of administration and time limited versus indefinite treatment, and sort of what is available and comfortable with the institution.
So do you see that the need, at least during one or two of the first infusion during the step-up dosing, we know we start with low dose of these antibodies in order to prevent the side effect discussed in another session. But do you think that the need to hospitalize this patient at least one or twice is really an important constraint, or will not facilitate the approval or the dissemination of this drug? How do you see that in your practice?
Yeah, that's a great question. The approvals in the trials that led to the approval, there was hospitalization required for the initial doses where the CRS, cytokine release syndrome side effects are the highest with the initial doses. But, at our institution, CAR T is now largely moved to the outpatient setting, except for patients who are more frail or may not tolerate this in the outpatient. So I think bispecifics can also start to move in the outpatient setting, and we are starting to explore that at our institution. And I think that will really significantly reduce cost and healthcare utilization and allow more access to these treatments. And I think as we get more experience and comfort with the administration of these drugs and managing the side effects, I think we can move towards more outpatient administration.
Yeah, I think the guardrails in place now, though, are appropriate for bispecifics as we've become comfortable with them because we've all used them in clinical trials. As they're commercialized and as they make their way into the community setting, I think it is reasonable to provide certain advice or expert advice on how we've employed the risk mitigation, the toxicity management, not forgetting to give obinutuzumab prior to glofitamab. The steroids that are required, post epcoritamab, as well as that was how it was developed. And then really trying to tease out the toxicity management differences that wasn't really bore out well in the clinical trials, but also understanding when the peak risk is. As you all know, with cycle 1 or the first dose of glofitamab, following the obinutuzumab dose is the highest risk for CRS. But it isn't the same time point with epcoritamab, which is your cycle 1 day 15 dosing with that drug. And so there are some unique subtleties. I'm still kind of racking my brain on when to use glofitamab and when to use epcoritamab in a commercial environment in relapsed refractory large cell lymphoma, because we just know that there's not going to be a head-to-head trial.
So, we addressed the role of this antibody in diffuse large B-cell lymphoma, but, the indolent lymphoma, and these patients, as we know, live for years, have multiple relapse, and go over different options. So, Dr. Kambhampati, can you come back a little bit to the experience of these drugs in indolent B-cell lymphoma, where they develop only in follicular lymphoma and follicular and others? What are the current data? Which one is currently approved? At least it's only one right now, mosunetuzumab. How do we see the future? And well, at the end, where do you integrate this option in your treatment algorithm for this patient?
Yeah, thank you, Dr. Salles. Yeah, I think all of these bispecifics in the initial phase 1 and dose expansion studies were explored in a variety of B-cell non-Hodgkin lymphoma, namely diffuse large B-cell and follicular is really the main histologies that they've been explored in, with largely, and that where we have the data. And only one of them, mosunetuzumab, is currently approved in follicular lymphoma. And the data looks really good in the relapse setting, and what's with an overall response rate of 60% and high proportion of patients achieving CR. And what's really exciting is this toxicity is very low. Mosunetuzumab has very low rates of CRS and virtually non-existent ICANS. And these toxicities are present with CAR T-cell therapy, which is also approved based on the ZUMA-5 study for patients with relapsed refractory follicular lymphoma. So when I see patients who have relapsed after initial, chemoimmunotherapy and R-squared, and thinking about sort of what regimen to give them, whether CAR T or bispecific, I tend to go to bispecific before CAR T cell because of the response seen and safety profile observed. And now there's studies looking at combination of bispecifics with Revlimid and other agents, and also frontline studies, because we have, though the follow-up is short, we have observed some durable responses in these patients. And so the thought is, could using bispecifics earlier, where the T cells are more effective, and could that lead to maybe long durable cures in these patients?
So maybe before we come back to the first-line therapy and the role of bispecific in this setting, I have another quick question for you, Dr. Lunning. If you see a patient that had failed bendamustine, rituximab, R-square, maybe another option, even R-CHOP, and this patient is potentially eligible for CAR T-cell therapy or mosunetuzumab, follicular lymphoma patient, how do you address the discussion with the patient?
Yeah, I think it's a discussion of all eggs in one basket, or dropping an egg along the way with the potential that you could, save CAR T cell for another day. I think there's much less data, however, of giving, mosunetuzumab followed by CAR. We're gaining experience of CAR, and then with the bispecifics to follow. But I, like Dr. Kambhampati, I'm having the discussion of putting bispecifics before CAR in that regard, because mosunetuzumab, if you get a CR, you're done. You put it back on the shelf. You give the T cells a break, and I think that we're going to see a lot of patients get to that 8 cycles, and then come off of therapy with follicular lymphoma. And I think the data that we don't have right now is, if their disease comes back after mosunetuzumab, what's the odds that they go back into a CR? And is it like vitamin R, where you can just continue to recycle it? And we're going to be talking 5 years from now about vitamin M, in follicular lymphoma, where you just squeeze, a couple of doses more of mosunetuzumab in, you tickle the T cells destroy the disease, and here we are changing, once again, the paradigm of follicular lymphoma.
So thank you for that. And maybe just to close this segment, we alluded to the fact that some first-line therapy trials are being developed. And maybe we can come back to the indolent field. And Dr. Kambhampati, you started to address mosunetuzumab in this patient with indolent malignancies. Do you think this is a drug that will go as a single agent in this field? Do you think it will be combined with lenalidomide? How do you see the field moving forward? How do you think it can eventually compete with what we already have in the first line, which is so effective?
Yeah, that's a great question, Dr. Salles. I think there are many studies that are ongoing with initial results reported that have shown that these bispecifics in indolent histologies can be very effective and combined with other standard therapies, like epcoritamab has shown high responses when combined with R-squared, and even in both frontline setting and relapse setting, and included patients who were POD24 or progression of disease within 24 months and high-risk patients. We also have frontline mosunetuzumab data that looks very promising in both in indolent histologies. And I think, and there's ongoing studies looking at mosunetuzumab in combination with lenalidomide compared to R-square. So I think I see the field sort of looking at combination of these agents and really moving towards probably combining the standard of care agents with these bispecifics and potentially using them earlier to spare chemotherapy and improve responses for patients.
Well, thank you. Dr. Lunning, you already mentioned that you were impressed by the R-CHOP plus one of the bispecific in the frontline setting. I think it was glofitamab. Can you tell us a little bit if there is a way to use one of these antibody in combination, for instance, with polatuzumab in the first-line setting in patients that are unfit for chemotherapy?
Yeah, I think that we're now learning how to use polatuzumab and seeing what agents play nicely in the sandbox, with that. And I do think that this was going to be, a doublet to explore. I think it is going to replace potentially chemotherapy if you consider antibody drug conjugates, your classical chemotherapy.
Well, I was thinking that this will be reserved at the beginning, maybe for patients not eligible, but I see you are very ambitious and very optimistic. It doesn't surprise me, but I think this is a great conclusion. So thank you again for joining us for this segment on efficacy of bispecific antibodies in large B-cell lymphoma and indolent B-cell lymphoma. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPA credits, access supplemental slides, very important, as well as other topic segments and case scenarios. Thank you again.